Thank you so much, sir. Next, we have a session on umbilical cord management led by Dr. Sumesh Thomas. To moderate the session, we have Dr. Rakesh B. Dr. Rakesh B is a consultant at Pediatrics and Neonatology Department in Daya Hospital, Thrissur. He is the current president of Indian Academy of Pediatrics, Thrissur, the branch that is hosting the IAP Neocon 2022. We kindly welcome you, sir, to the stage.
Dr. Sumesh Thomas is a clinical associate professor of pediatrics at Cummings School of Medicine, the University of Calgary. He will be the speaker of this session. We welcome you, sir.
Good evening. So today we have this session on this umbilical cord management. Well, it sounds simple, but then there are challenges. And to speak about this, we have the right person. We have Dr. Sumesh. So he is a consultant, clinical professor and neonatologist. He's a medical director of Southern Alberta Neonatal Transport Service. He's the director for the SCAN program. His main interests are neonatal transport and the medical legal implications of neonatal practice, and also the ultrasound scan in neonates. So he's involved in medical legal work for over 10 years and as a medical expert and educator for medical practitioners and trainees. His formal training in medical law was in 2013. So let's hear from Dr. Sumesh Thomas. Over to you.
Thank you very much, everyone. I'm going to try and keep you all awake for the next 20 minutes. I just want to get a sense from the crowd here about how many centers that you all work in where delayed cord clamping is the standard of care. Excellent. Well, it looks like I might just as well leave right now. Or anyhow, let's try and make a little bit more sense of what we're doing. I have the task of talking about an ancient topic. And by the sense I talk about this from the perspective of it stems from the evolution of the mammal. We will, in this discussion, cover a little bit about the physiology of placental transfusion, some of the current challenges, and what does the future look like with regards to cord management. So this is a quote from 1773. The common method of tying and cutting the navel string in the instant the child is born is likewise one of those errors in practice that has nothing to plead in favor but custom. The reality is that that is still the case in many places around the world. This physician in 1930, who is known to be the father of modern obstetrics, I found this quote very interesting because he had quite an in-depth sort of knowledge of how the placental transfusion did take place. The blood is pressed into the child by uterine contractions and is part aspirated by the expanding lungs. Children that don't have this essentially are less well and subject to disease. He, way back then in 1930, spoke about the potential harm of cord milking or stripping. And that was, to me, very insightful, a comment from as early as the early 1990s. So what does the fetal transition look like? Essentially, in the second trimester of pregnancy, the circulating blood volume of the fetus is somewhere between 100 and 120 mils per kg. About 50% of that amount remains in the placenta when you're dealing with a preterm infant. This becomes extremely relevant when we look about especially major morbidities such as significant intraventricular hemorrhages. So as described by Dr. DeLong, the mechanism involves uterine contraction, the very process of being expelled from the uterus, exposure to extrauterine environment, and importantly, newborn breathing. So the reality is that it is very much a push of blood into the fetus as it is an actual pull of blood into the fetus, except we need to remember that the critical piece to achieve the aspiration or the pool of blood is actually breathing, establishment of respiration. And to understand that is to understand a little bit about this picture. Because essentially once the fetus transitions, there is a cry, or should be a cry. And with that cry is an increase in functional residual capacity. With exposure to air and oxygen, there is a decrease in pulmonary vascular resistance. And with that, an increase in right ventricular output, a decrease in peripheral vascular, pulmonary vascular dilatation and lung perfusion. And with that, you also have increased amounts of blood returning to the left ventricle and inevitably an increase in your cardiac output. And with an increase in PaO2, your PDA flow also drops. So the net effect of that is actually an increase in systemic perfusion. Now let's sort of compare that to what happens when you have immediate cord clamping. There is an immediate drop in the amount of blood entering into the right ventricle, or the preload. There is also an increase in the left ventricular, peripheral vascular resistance once the umbilical artery is clamped. If you do not have lung expansion at that point, it just stands to reason that the blood circulation basically steals from vital organs, such as the brain. And you have this brief drop in systemic perfusion. This particular sort of phenomenon has been well published on since sort of the mid-2000s, mostly by a physiologist by the name of Hooper in Australia, who described the sort of changes in cardiac output and systemic blood pressure with ventilation prior to cord clamping and cord clamping prior to ventilation. And the difference is basically, if you cut the cord before ventilation is established, you will have a drop in your cardiac output, a drop in your systemic blood pressure, and it is quite likely that that is why there is an increased incidence of intraventricular hemorrhage, especially in the preterm population. So let's look at the current recommendations. Way back in 2012, because this is kind of old stuff now, it was recommended that in newly born term or preterm infants who do not require positive air pressure ventilation, the cord should be clamped earlier, should not be clamped earlier than 1 minute after birth. This is a strong recommendation. I have not edited any of these pieces. They are lifted directly out of the World Health Organization document. The late cord clamping, performed approximately between 1 to 3 minutes of birth, is recommended for all births while initiating simultaneously the simultaneous essential non-neonatal care pieces. Again, classed as a strong recommendation. And then within the context of the guidelines of newborn resuscitation, they even go as far as saying if there is experience in providing effective positive pressure ventilation without cutting the cord, this should be initiated. So even the World Health Organization had proposed the concept of resuscitation on placental circulation. So ILCOR and LLS had basically come up with recommendations proposing at least 30 seconds of delay for babies that are not requiring resuscitation. And as recently as 2021, the Resuscitation Council of the United Kingdom has suggested that you should aim for at least 60 seconds of delayed cord clamping. And if this is not possible, cord milking is an option for babies greater than 28 weeks, because the more recent evidence is raised concerns about the practice of cord milking in premature infants. And you can understand that if the lungs have not expanded and you suddenly strip blood into the fetus, it is likely that that's going to be directed to vulnerable vasculature such as that of the brain tissue. The European Council has a similar sort of recommendation where they say immediate resuscitation or where immediate resuscitation or stabilization is not required, aim to delay clamping the cord for at least 60 seconds. A longer period may be beneficial, and clamping should ideally take place after the lungs are aerated. And similarly, they propose that if there is no possibility of delaying cord clamping, cord milking can be considered for babies greater than 28 weeks gestation. A similar sort of recommendation, rather bolder though, has come out from the Society of Obstetrics and Gynecology in Canada, where they propose delayed cord clamping for babies who are preterm and suggesting durations as long as 2 minutes, because it decreases newborn mortality and morbidity and improves the hematological outcomes after the newborn period. And where they have said that it has not been possible to defer cord clamping, that you should aim at least to give 30 seconds. They, however, have categorically stated that umbilical cord milking is not recommended for preterm infants less than 32 weeks. This is the current state of affairs with regards to recommendations. So what are the challenges? The challenges. We clearly know that one of the greatest challenges we have is the limitation associated with the need or the perceived need for immediate neonatal resuscitation. And in some ways, point 1 and point 5 hang together, because sometimes we assume that the baby is bradycardic and therefore interrupt delayed cord clamping. What is the optimal duration for delayed cord clamping remains unclear. And there is at this time a conflict in terms of delayed cord clamping and the ability to collect cord blood for stem cell banking. I'm not sure if that is actually an issue here in India, but certainly in the Western world, it is becoming a challenge. We also recognize that there are differences in practice for deliveries in the healthcare setting at home and in hospital settings. What we do know is that if you're born greater than 33 weeks gestation, there's a significant possibility you will be able to have at least 60 seconds of delayed cord clamping. If you're less than 33 weeks, that possibility drops to less than 70%. So as I talked about earlier on, one of the key elements in terms of deciding who do we abruptly stop this delayed cord clamping comes from, well, let's see what the heart rate is doing. Many of you recognize there are limitations with conventional methods that we use, and these include auscultation, palpation, pulse oximetry, and then come to the conclusion that ECG monitoring is probably currently the most accurate form of assessment. But if you just look beyond technology, many of you would remember looking at cords and seeing this sort of thing happening, where the cord gradually over a period of time empties of blood. Now let's look a little closer at the umbilical cord. And there's a reason I want us to do this. It's because even from very basic biology or anatomy, we recognize that the umbilical vein is a thin-walled, easily compressible vessel as compared to the umbilical arteries. It therefore stands to reason that the moment you palpate a cord and you are able to feel a pulsation, you are almost certainly compressing the vein at the same time, and therefore interrupting cord, the placental transfusion. So really we have to ask ourselves the question, is it necessary to determine heart rate if the baby has a good tone, is breathing and or crying? In the context that if you did palpate the cord, you're possibly interrupting placental flow. And there is published literature that talks about the limitations or inaccuracies associated with palpation of the cord. So therefore, what I would propose to you that our time is probably much better spent ensuring that we position these newly born infants, try to provide some stimulation, and avoid touching their cords while preparing to abort delayed cord clamping if the baby is not breathing. I think it's important to recognize that the benefits of delayed cord clamping are intricately linked to newborn breathing. And so that's where the future takes us. There are opportunities for research looking at the outcomes of neonatal resuscitation performed while the umbilical cord blood is intact. Calgary is one of the centers involved in an NIH-funded study right now called Vent First, looking at the impact of resuscitating preterm infants less than 29 weeks for as long as 2 minutes while attached to the cord. What is the optimal time of the use of uterotonics? What is the optimal position for babies when they are transitioning? What would be excellent is the ability to quantify the amount of blood transfer. We tried, but not successfully, to try and do this in our center in Calgary. Because in doing so, we may be actually able to postulate some sort of correlation between that and the amount of stem cell transfer. It's also going to be invaluable to look at the analysis of cost benefits associated with delayed umbilical cord clamping. So to have this happen, there are several places across the world where platforms are being developed. I've started off with the one from the US. There's one from Canada and from the Netherlands. And some of these are commercially available. But the ultimate objective of these devices is actually to try and establish breathing artificially, if necessary, for transitioning vulnerable babies. Because right now, there are a number of babies that are automatically excluded from the benefits of delayed cord clamping. I'm going to share with you a video that I have taken around the world whenever I talk about delayed cord clamping. And the reason for this is because every time I watch it, I am amazed at what our primate relatives have been doing way before we came up with NRP. It's about the birth of a baby orangutan. Could we have some help with the video? Oh, yes. Oh, it was already playing. I need to go back. Could you go back, please? Okay, so we've just seen the delivery of a baby orangutan. Yeah, so that's the birth just happening. And you will notice that this newborn is relatively inactive at certain points. I'm not suggesting that we revert to licking the feet of the babies, but you can see how floppy that newborn is. And you will notice what this mother, who has never read an NRP textbook, does. There she is. She sucks out secretions from the airway. And in doing so, she is stimulating the newborn to breathe. The cord is left intact. And if you watch that, this is what happens in nature. I would suggest to you that there is very little more compelling evidence about what is probably part of our evolutionary history. And the fact that we've ended up in an era where early cord clamping, certainly for a large proportion of our modern medical practice, had been considered normal. I would suggest to you there is nothing normal about early cord clamping. It is an abnormal adaptive change, and that we need to look at better ways of optimizing delayed cord clamping and allowing our newborn infants to benefit from the extra blood that they get, which, as many of you have probably come across, the literature is beginning to suggest that the benefits of delayed cord clamping exist way beyond the perinatal period, probably into childhood, and even possibly into adulthood. Because, you know, one could argue that the stem cell transfer offers a unique opportunity for repair of organ systems that we at this time are deprived of with early cord clamping. So on that note, I'm going to stop and take any questions for the next couple of minutes.
Any questions?
I take it we're all sold then. Was it the orangutan that did it? Because for me, every time I've looked at that video, I am astounded by what is instinctive in mammals. That instinct to stimulate soon after birth, that instinct to clear the airway and promote breathing, that's instinctive. And I think there's a very important piece that I want to leave us with, and that's the piece that I talked about in terms of cord palpation. If there is nothing else you take away from this talk today, I ask you to please think about the potential disservice associated with cord palpation as a means of assessing heart rate during delayed cord clamping. Because from an anatomical standpoint, it doesn't quite make a lot of sense. So I don't have all the answers, but I certainly have lots of questions. And I think that there will be a lot more information over the next decade or so with regards to delayed cord clamping and what might be the optimal answer, the optimal durations for some of those parameters we discussed.
Thank you.
Thank you.
Excuse me, sir, I have a question.
Yes.
Is there any particular position recommended for delayed cord clamping? Shall we keep the baby down to have a benefit of gravity, or just, and what is to be done in the case of C-section?
There's conflicting literature about that. Some have suggested that it doesn't make a difference. Some have suggested that it is better to have the baby lower. The reality is that for those of us who do delayed cord clamping during cesarean sections, inevitably the babies are above. So I think the answer to your question lies in future research that needs to be had with regards to different circumstances around birth.
Okay, thank you.
Because in answering that question, the reality is that, does it matter in terms of where the position is if you're using a uterotonic versus not? So I think it's important to look at the literature and answer these questions specific to the question that you really want answered.
Yeah, if no more questions,
Well,
thank you. Thank you, Dr. Sumesh Thomas. It's definitely a challenge ahead, and I think it's the right thing, and more challenges for the future to come, and hopefully we get more answers for the next 1 year or so.
Thank you. I hope so too.
Yeah. So let's wind up the session. Thank you. Thank you.
Thank you, Dr. Sumesh, for enlightening us on the topic. We would also like to extend our sincere gratitude to Dr. Rakesh for his contributions to the session.